It's mainly what we see on a daily basis is the diabetic nephropathy. Then it can have also infection is part of the complication. Diabetic patients will have more tendency to have pyelonephritis and cystitis. And also we cannot forget the renal tubular necrosis, which is usually follows a urethral or a contrast-induced nephropathy. So, diabetic nephropathy. In an early stages, it will be accompanied by hyperfiltration. But mainly this will happen in diabetic type 1. And then moderately increase in the albuminuria, formerly called microalbuminuria, which is defined by urinary albumin extraction between 30 to 300 microgram per day or between 30 to 300 microgram per gram of creatinine in a random urine sample. And this is usually, it's part of your workup in a diabetic patient to follow closely the complication of diabetic nephropathy. And we usually do this test so we can interfere early and prevent the progression of diabetic nephropathy. So, in a severely increased albuminuria, it's formally called macroalbuminuria, which is defined by more than 300 milligram per day. In the absence of effective therapy, followed by slowly progression decline in the glomerular filtration rate, this will lead to end-stage renal disease if you do not interfere and start the patient on treatment. That will decrease this macroalbuminuria. The prevalence of diabetic nephropathy, it's really very prevalent in diabetic type 1. It's around 20 to 30% within 15 years. It will reach up to 40% within 20 years of diagnosis of diabetic type 1. And end-stage renal disease in diabetic type 1, it usually can occur up to 17% within 20 years of diagnosis. In diabetic type 2, nevertheless, there is a chance of 15 to 30% that they will develop some kind of renal disease within 10 years of diagnosis. This has been proven in UK PDS. This was proven in UK PDS study that at 10 years following the diagnosis, the prevalence of moderately increased albuminuria can reach up to 25 or 25% of the population. Over 40% of the new cases of end-stage renal disease around the world will be related to diabetes. Diabetic nephropathy is the second most common chronic diabetic complication that occur in Saudi population. It can occur up to 32% of the diabetic patient. They will have some kind of diabetic nephropathy. And usually it will occur within the mean of around 12 years. And this has been shown in 2 studies that it will occur between 10 to 12 years since the day of diagnosis with diabetes. And therefore, we need to protect our patients. Clues to suggest that what happens, there are always, you will find the case that you will face and you will ask, is this renal failure secondary to diabetes complication? Is it a nephropathy? Or is it an acute non-diabetic related complication? Now we will describe some of the clues that will differentiate between a diabetic nephropathy compared to other diseases that can cause renal failure in the same patient population. Number 1 is the onset of proteinuria. Less than 5 years from the onset of diabetic type 1, it will make it less likely to be related to diabetes, and you have to look for another cause. If the acute renal failure happened, if it happened acutely, this is most likely you need to look for other cause other than diabetes. Number 3, the presence of an active urine sediment, particularly if you see an athenocytes or a cellular cast. And this is why it's very, very important to send your patient urine for urine analysis and to look for cellular cast. This will make it unlikely that it's related to diabetes, and you have to find another cause that you can treat to prevent further progression. In type 1 diabetics, the absence of diabetic retinopathy or neuropathy, and there is nephropathy, usually this doesn't fit. Usually nephropathy will be preceded by retinopathy and neuropathy, which will occur much earlier than nephropathy. Therefore, if you have a patient diabetic type 1 who have nephropathy, then that he have nephropathy without retinopathy or neuropathy, then please look for another cause other than diabetes. Maybe you can treat. Number 5, if there is any signs of symptoms for another systemic disease. And number 6, if there is significant reduction of glomerular filtration rate, more than 30% within 2 to 3 months, this is usually not related to diabetes. If it happens so acutely and so fast, usually you have to send your patient for a kidney biopsy to check for other causes other than diabetes. Maybe you can treat and prevent further progression. Risk factor for diabetic nephropathy, as we just said, family history of diabetes and diabetic nephropathy will make it most likely that it will happen to all the other siblings. Black race, certain ethnicities like Mexican and American and Indians, higher systemic blood pressure. So if there is diabetes and uncontrolled blood pressure, this will make it higher chance for the patient to develop diabetic nephropathy. If there is an evidence of hyperfiltration, or if there is a poor glycemic control, smoking, and obesity. Treatment and prevention of diabetic nephropathy. Again, good diabetic control. Good blood pressure control now is also, as we said, is a very important factor for prevention of progression of diabetic nephropathy. So controlling the blood pressure with less than 130/80 is your target, and ACE and ARB is your preferred agent. And ACE and ARB is your preferred agent, especially if you have macroalbuminuria, that it will prevent this kind of complication. You also have to treat hyperlipidemia, and if progressed, renal replacement therapy and renal transplantation is the end treatment for diabetic nephropathy that can be leading to end-stage renal disease. Screening for diabetic nephropathy, usually the blood pressure, you check it every visit and make sure that the blood pressure is well controlled at home, not only in your clinic. So you let the patient really record in a weekly basis or in a daily basis his blood pressure recording and measurement. For urine albumin ratio, for urine albumin to creatinine ratio, you do it in a yearly basis. You begin with 3 to 5 years after the onset of diabetes type 1. And the serum creatinine, you do it annually, not every 3 months. Except if you find there is a progression or a renal disease, then you have to do it in a much shorter duration. Causes of transient proteinuria. So you might see a proteinuria in your patient that it is unusual, that you never saw in his previous visit in 3 months ago. Then you have to think about other causes for a transient proteinuria. Number 1 is febrile illness. It is very common that the patient will get a febrile illness that will lead to proteinuria. Urinary tract infection is the other cause. Recent major exercise, decompensated heart failure, menstruation, acute severe elevation of blood sugar, and acute severe elevation of blood pressure.